This is a pleasure for me to talk a little bit about oncologic outcomes after VATS resection because in the end they're fine, but you have to observe the principles. So this is an interesting history, particularly to share the podium with Robert and Herbert here because it has been an evolution over time. 25 years ago when VATS, 26, when VATS really began, there were some people doing VATS lobectomies, Ralph Lewis and others doing cis lobectomies, and I did a few VATS lobectomies in those early years, and I'm certain I'm going to die 10 years early as a result of it. But and then I didn't see the point of it, and so I went to minimally invasive thoracotomy and so on. But 20 years ago, there were some early adopters doing outstanding work. And I'd say over the last 10 years, VATS lobectomy for early stage lung cancer is the standard of care. The problem is it's not being applied widely. Now, you could argue that robotics should be the standard of care as well, but it's expensive and difficult. But minimally invasive is the point. It's interesting that, Robert went from being, he wasn't an early adopter either. He kind of went from an open thoracotomy to robotic almost overnight. So there's different ways of doing things, but the oncologic principles are the same. And whether it's 3 ports, 2 ports, 1 port, we're talking about pain, really, perhaps access to a certain extent, but all of these operations, wedge, lobectomy, sleeve resection, pneumonectomy, carinal resections are all being done VATS and with perfectly good results. In fact, there's been some recent reports of doing such operations in patients while they are awake without endotracheal intubation, which is remarkable. So the VATS operation or thoracoscopic lobectomy preserves all of these important anatomic principles. As I said, I think it is the standard of care. And there has been a marked increase in application. We'll get to a little bit of that. There's some data available from the United States and elsewhere that demonstrates an increase, but still a long way to go. And so here's a typical early stage lung cancer, quite suitable for VATS resection, a case similar to the one Robert showed with chest wall invasion, and you can certainly do an extensive chest wall resection VATS. I think that we would not attempt an operation like this VATS, a pan-coast resection with following induction therapy. You can see the patients had a good clinical response. But we've done quite a few of these operations hybrid so that we do the VATS portion of it, detach the lobe, do some of the chest wall resection from inside, and then with our neurosurgical or orthopedic colleagues can make a very small posterior muscle-sparing incision and pull the specimen out from the back. And I think that's an attractive option as well. We have not used VATS approach for such central T4 tumors as you see here, but several authors in China have reported really quite good results doing carinal resection using video minimally invasive techniques. So I think the future is very bright for minimally invasive surgery. Now, I think at present, what's the state of VATS lobectomy as an oncologic strategy? There's imperfect, non-randomized data, and I'd say it's going to be a long time before there's any really good randomized data. Suggests that VATS lobectomy, equivalent or better survival, lower complication rates than open, equivalent acute mortality rate, particularly in older patients, comparable lymph node resection rates, fewer delays in chemotherapy delivery, the Duke experience, may be associated with reduced inflammatory response, less post-op pain, and definitely better outcomes in patients with poor pulmonary function. And some of those early adopters did report their experience early on. This is Rob McKenna's report from more than 10 years ago with 1,100 patients, and you can see that the stage distribution, and like all good cancer resection reports, there is an upstaging that goes on as a result of detailed operative technique and good node dissection. So if you see in the clinical and the post-operative pathologic stage the same, it means those patients were having bad surgery. But excellent results, very few conversions and short hospital stay, and a very nice distribution stage by stage in terms of survival. And once again, the Duke experience that I mentioned a minute ago is from more than 10 years ago, a large experience of patients, most patients having non-small cell lung cancer, really excellent results with zero operative mortality and minimal morbidity, and good survival by stage. So excellent results, and those were single-station reports, and there's only one or two small multi-center trials. Now, this is an interesting study. This was actually published in the Journal of Clinical Oncology, and the reason was because it was a study group report that originated through the CALGB. David Sugarbaker, I think, was the leader of that group at the time, but it constituted 11 surgeons in 6 centers. It's a relatively small experience, but it was started out as a feasibility study. And once again, the results were quite good. The op time was maybe a bit long, but the survival was good and limited perioperative mortality. Now, I want to just close with two recent reports. These are database reports, and the purpose is not this basically. Well, it has something to do with VATS, so it's interesting, but it has to do with database. What information comes from database? So Herbert mentioned database, and you guys produced a really excellent study on complications that came from, what, 6 centers? Huge number of patients. The advantage of that study, what you talked about, is that you actually know the results. You actually know the complications, conversions, and so on. That you can't get that, as you mentioned, you cannot get that information from a database study. Well, anyway, I'm going to be talking tomorrow about the STS database and its pros and cons of it. But this is a study that Mark Onitis and a number of other STS investigators just described in a very recent report. And it had to do with trying to develop a survival prediction for patients using patients entered into the STS database. The results aren't that important. I mean, you would imagine that the prediction of survival for a young, healthy patient is better than for an older, infirm patient. And that's basically what they found. But in this, and this paper was based, there was the major point of the paper was older patients do poorly. Hello, right. So I'm not going to show you any of the data because it's really not important. What's important is that these are data reported to the STS General Thoracic Surgery database, which includes thousands of patients contributed by a large number of surgeons, both academic and community hospital-based surgeons, more academic than community hospital-based, but nonetheless, the penetration of VATS in this very recent report still only 50% or a little less nationally. Higher in academic centers, but still, there's a big opportunity for further application of VATS. And as Robert said, this has to do with training and team education to do minimally invasive surgery. And another important study that was just recently reported at the Western, and I think will be published soon in the JTCVS, is this issue of nodal upstaging. Can you do an adequate node dissection utilizing a VATS strategy or robotic strategy in comparison to open? Because there had been a study from the STS database a couple of years ago that Dan Boffa wrote that suggested that the node dissection done VATS was much inferior to that done open. Now bear in mind that there is a quality metric that says if you don't do at least 10 lymph nodes during a routine lung cancer operation, then you're doing an inadequate resection. So bear that number 10 in mind for a few minutes. So this was a retrospective review from the National Cancer Database. Now the National Cancer Database is a completely different database. This is an administrative database, and it's administered by the American College of Surgeons and the American Cancer Society. It captures about 70% of cancer patients in the United States. Most lung cancer, huge numbers, thousands and thousands, tens of thousands of patients, as you'll see. So what they were looking at was VATS versus open, and in a large number of patients, you could see like more than 16,000 patients. So 2/3, once again, this is not the STS database, the National Cancer Base, a bigger experience with many more surgeons involved. 2/3 of cases are still being done via thoracotomy. This is for early stage lung cancer. And the variability, the number of VATS cases is much higher in the academic centers and much lower in the community hospital centers. It would seem that the incidence of nodal upstage, I'm not going to share the data because it really doesn't matter a great deal. It looks as though that the higher rate of nodal upstaging is higher in a group of patients who undergo an open operation versus VATS, but the number of lymph node samples is much higher in the VATS group, interestingly. And if they did a subset analysis among those patients who had more than 7 lymph nodes sampled. And in those patients, the mean number of lymph nodes sampled was actually 13 and some. And in those patients wherein a large number of lymph nodes were sampled, in this slide here, the difference in upstaging disappears. So the bottom line is, it doesn't really matter whether you're doing an operation open or closed. What you really need to do is a very detailed node dissection. And unfortunately, in the overall group, the mean number of lymph nodes sampled was like 9, but the range, the standard error was like 7. So there's patients in the United States having operations for lung cancer having very few lymph nodes sampled, even now in this day and age. It's outrageous. So we've got a lot of work to do. There's nothing wrong with VATS as an oncologic operation, but you have to do an actual oncologic operation, complete resection, and a thorough lymph node examination, whether that's by lymph node sampling or dissection. Thank you.